Welcome back to Electrolysis Unplugged, the podcast where we talk about the real world of electrology, the decisions that don't always have a textbook answer, the gray areas, the moments where clinical skill meets ethics, boundaries, and humanity.
And in today's episode, it was inspired by a recent PCOS conversation on Instagram that opened up the door to a much bigger discussion: hormones, pregnancy, chronic skin conditions, and knowing when not to treat.
This episode is about restraint as a professional skill, about slowing down, about understanding when hair is a symptom, not the problem. Hello, everyone.
So, are you ready to kick this off? I feel like we have a good amount of information to go over. We had some great questions come through. The first one being from Crystal. So I hope that she pops on here later on so that she gets to hear this live. But it comes to us about PCOS. So this episode, we want to call it that, right? Was inspired by a recent post that was on Instagram. It's actually a post that I've gotten to see quite a few times as a patient and an advocate in that space. It really did open the door to a much bigger discussion than what those 17 slides show. And we definitely can post the link in the chat. I do have it saved in a little bit. But it opened the door to this discussion because for me, it's a personal struggle, like as a PCOS patient, but as a professional struggle as well. I mean, I see people like me all the time that struggle with a lot of the same comorbidities, just not having a voice.
So it was a post about PCOS?
Yeah, it was. So let's talk about it. I'm gonna briefly read off the title of it. PCOS being acknowledged as an intersex variability, meaning patients with PCOS often can be also categorized underneath the intersex characteristics. So intersex is a term that sounds new. It is not. And I will not be using the derogatory term from the past, but it is someone who has characteristics in their sex development of their body that do not align to strictly assigned male at birth or assigned female at birth. So many of the things that happen with patients with PCOS is we kind of put everybody into this little, like, this is where you belong. If you have PCOS, you're assigned female at birth, you're a woman, you can't have babies, you're going to be overweight, you're going to be hairy, all this acne is coming at you, and this is what you get. You get what you get, and you don't throw a fit, okay? The problem is the research is showing a lot more. So as we talk about this, I'm just going to go like kind of a little bit ahead of there. We don't talk well about PCOS and the care our patients face in general. Many of our patients are struggling with multiple care providers. Pretty much the average is about 7 care providers before diagnosis, and that's diagnosis, not treatment, okay? And in that same space, a lot of the stuff that we're going after with PCOS is not usually in the scope of practice amongst providers that are under or in care of insurance. So a lot of the care that's being spent with PCOS patients is actually in specialty offices that cost them more. They are in spaces where they are working with naturopaths and nurse practitioners that might have to work in other spaces because the MDs and the DOs aren't really dedicating time to it. But we, in the advocacy and the research side of things of PCOS and the patient care side of things of PCOS, we are seeing that's increasingly being recognized as intersex-related characteristic, meaning that it simply exists on the spectrum of sex development variations. And that does not align with like part of many PCOS patients' diagnosis at this time. So that's where we're at right now.
And I know that the language can feel pretty complicated for people.
Yeah, it can. And to be very clear here, I myself, I don't identify as an intersex person. She, her pronouns, I say cis woman. I also don't have an official diagnosis with intersex characteristics. So I am one of those people that I'm trying my best not to self-diagnose on TikTok as much as possible. Doesn't always work, and it doesn't always mean that it's the right thing to do, because sometimes it helps open the conversation in this space, which is kind of what it did for me in this space. As I learned as an advocate the PCOS side of things with intersex characteristics, it allowed me to have deeper conversations about that. There are additional diagnostic criteria, such as evaluations, medical determinations that would need to be in place for that to be an accurate label for myself. But it is a real statement, if that makes sense. The realities of intersex characteristics is a real statement for PCOS patients.
And that distinction matters quite a bit.
Absolutely, it does. What also matters in that space is understanding that PCOS has never only impacted patients assigned female at birth. And I'm going to say that with my whole chest right now. It does not impact only patients assigned female at birth, even though that is how it was originally framed.
So that goes all the way back to the Stein-Leventhal.
Oh, yeah. So Stein-Leventhal, if you guys don't know this, PCOS had a previous name, okay? Back in 1935, Irving Stein and Michael Leventhal described a cluster of symptoms that included inability to ovulate appropriately or lack of ovulation, hyperandrogenism, so male pattern hair hormones, and polycystic ovaries. As a medical understanding, it evolved and it was recognized that PCOS was vastly more complex as a hormonal disorder with a much wider range of manifestations than initially described, which is why the more encompassing term of PCOS was now used, even though there are people in the PCOS advocacy community that are trying to change that. It's like we finally have enough people to understand it. The problem is now we understand that we went too narrow on ovaries, menstruation, and fertility. And now what we understand is it's about hormonal patterns in PCOS patients. They don't stop there.
Well, a lot of the reason, I think a lot of people they're not getting the diagnosis, or they're getting misdiagnosed because people are still so focused on the ovary thing.
Oh, yeah.
And so it's like you have it in the name, but then they tell people that, yeah, but cystic ovaries aren't really, like you can have no cysts and still have PCOS. And then it just kind of gets you scratching your head. You're like, but it's literally polycystic ovarian syndrome. It's in the name, so it's odd for sure renaming it. But then I remember this conversation because they also said that, when you have so much recognition behind a name, if you change the name, you risk like confusing people and losing a lot of the support that goes into that name.
Oh, yeah. Oh, yeah. I mean, think about this. Like, we know that assigned male at birth patients typically have a lot more studies done to make sure their health is tippity-top, right? And it was until, I think, October of 23 that we had our first, October of 23 that we had our first Men-C products tested with menstruation blood. Okay.
Yeah, and they use that pink water.
Yeah, the pink water or the blue water. I was like,
yeah,
that doesn't look me. And then the other big thing was a month later was our first FDA-approved drug development meeting for PCOS, which then promptly got tabled, and we have not had much forward movement since because of fertility issues and endocrine specialists being within the fertility realm more.
They want that money.
PCOS, yeah, they want that money. They want that like IUI, IVF, adoption dollars, like whatever. And they weren't doing anything to help the patient figure out if they could have a baby on their own. And it's been a mess. And I mean, I know that we talked about this in the past, but like bringing up the intersex portion of it, like when I say it's not just impacting assigned female at birth patients. So male offspring of an AFAB person, okay, also are impacted by many of the same issues that the PCOS patient has, minus the ovary portion. They will have all the other comorbidities and often still have infertility issues that present themselves in lower sperm counts and that kind of stuff for AMAB folks.
I mean, essentially, these, assigned male at birth, trans individuals, non-binary individuals can all be impacted by the same endocrine pathways. So long as you've got the same endocrine pathways, there's any kind of issues along that pathway could affect that patient.
Absolutely. And that realization is why the name itself has been underneath scrutiny for so long, because when we talk about that one anatomical feature, you basically put a blinder in front of you and say, it's fine.
Mm-hmm.
Yeah.
I mean, hormones don't care about gender labels, that's for sure.
Nah, they don't. PCOS affects hair growth, fertility, pregnancy outcomes, insulin resistance, inflammation issues, depression, heart. It is a major factor in early cancer screenings and that kind of stuff as well. It's across a much broader population than we originally acknowledged.
So Sandy actually posted a good question here in the chat. We'll read it out, but actually we're going to put a pin in it because it's part of today's conversation.
Ooh,
so she said, random question. I have a client who has PCOS and is getting ready to start trying to conceive. Any contraindications or reasons to stop electrolysis while attempting conception? So we'll talk about the pregnancy and trying to conceive pretty soon, actually.
Sandy, that was
how funny. It's like
perfect timing.
You smell. Are you looking at our notes?
Are you looking at my notes right now, Sandy? No. Oh, the struggle. I mean, I'm like trying to think that is exactly why we're here. I mean, our PCOS patients are a high risk patient typically, already, for fertility issues. And it's a big thing. I feel like I feel like I lost my notes. Give me back. Oh, there I am. Okay. So thank you. I appreciate you with the highlight. So, okay, we are finally seeing movement here, which is why myself, Stephanie Shields, a PCOS patient, would not like to see us change PCOS. I mean, I would like to see the O dropped. And I would, because what's interesting is in the PCOS world, cysts show up in other places of the body. They're just most prevalent in the ovaries. So I would like to see a little bit better on, hey, I like maybe like a, cystic body or blah, 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 blah. I don't know. But I
maybe they can just keep PCOS, but come up with different words for the letters.
Yeah, I'd be down for that too. We're finally seeing language evolve. We're seeing them realize that they were short-sighted. In research, we're seeing them finally realize like, oh, maybe we should pay attention because it's impacting up to 1 in 5 individuals. They range between 1 in 10 and 1 in 5, depending on whose study you see. 1 in 10 is US. 1 in 5 was global for a long time. I just tell people it's between 5 and 10 in that space. But as practitioners, we have a responsibility to understand that PCOS is so much more than facial hair. I think that our responsibility as a provider is to understand that diagnosis is not within our scope, but referrals are in that space. So get to know some people near you that are safe places to promote health at any size, health at any body, health at any gender, okay, in that spot. Because there is a systemic condition that intersects with the identity, the health access, the long-term care in this space. Telling women with PCOS that they have intersex characteristics in a society who is currently very unkind to women with facial hair can unravel a lot more. So finding the right words is going to help people understand how to listen without judgment. Because as we all know here, as electrologists, most of our patients have a substantial amount of shame around their unwanted hair, and don't have providers that know how problematic it is for their mental health.
Yeah, and I mean, that understanding really should directly inform how we treat and when we should pause.
Yeah, because hair is often like the visible part. It's rarely the whole story.
That's right.
So this is where Sandy's little 1-2 punch question came at the perfect time, because this is another great question that we had. Melissa had dropped in some working with patients with pregnancy, and then Sandy coming in with that punch at the end. We did a little bit of research. just to double check and make sure that we had the right verbiage. It gets tricky because guidance on working with patients with that are experiencing pregnancy or trying to conceive can be a little dicey.
Yeah, I mean, there's a lot of different recommendations out there. I think that most of us tend to stick to the same thing when it comes to, for example, Dextro International in their Academy Dextro. Their documents will recommend avoiding treatment in the first trimester. The AEA has historically said that treatments can be done with limitations in all stages of pregnancy, but sometimes avoiding later pregnancy.
Yeah.
So things are kind of all over the place. I have my thoughts on it, and we'll both share. But
Oh, yeah. Truth is, there's no universal consensus. So we default to risk mitigation, ethics, and documentation. Let's talk about first trimester, Joe.
so for the first trimester, I mean, for me, to treat or not to treat will depend on so many factors.
Yeah.
So the first trimester is a no treat zone for me if electrolysis causes you elevated levels of stress.
Agreed.
I mean, we've
Yeah.
kind of talked about it. Most of the time, people might not even know that they're pregnant, and so in the beginning, it's difficult to say. Obviously, and this goes back to Sandy's question. If we're talking about somebody that is actively trying to conceive,
Mm-hmm.
and electrolysis stresses her out because it's, there's some pain associated with it. And so if somebody comes in and it stresses them out, then stress and, people trying to conceive and having difficulty conceiving, it's not a good mix, right?
No. Yeah. I think that I think about my patients as we are asking them questions on their intake form, and we're asking about pregnancy, past pregnancies, that kind of stuff, to kind of get a gauge on what their hormones could be doing in their body. I also want to ask my clients, have you had experiences with inability to conceive? Are you trying to conceive in that space, especially when they're PCOS patients? You doing IVF or IUI in these spaces? So they're all methods of conceiving a child outside of traditional means. And I would say that one of the big things that we think about in a PCOS patient is early embryonic development in this space. Highest miscarriage risks are typically in this space. I will say that most people don't even know they're pregnant, especially if you have a PCOS patient that has had issues with menstruation. Because PCOS is not about not having your menses, it's about your menses being vastly irregular to the traditional person, assigned female at birth that menstruates.
This episode is sponsored by Silhouette Tone, a global leader in electrolysis equipment and aesthetic technology. From advanced epilators to full spa solutions, Silhouette Tone empowers professionals to deliver safe, effective treatments with innovation at every step. Discover their electrolysis equipment and more at silhouettetone.us.
So it's like, if you don't know you've been pregnant, you don't have periods on the regular, right? Our PCOS patients might not even know for a while that they have conceived at that point. And so I think that there is this part of it. It's like, why treat when the risks are high? There was this overabundance of caution comment that came a few years back in a lecture. And I look at this space as us operating with overabundance of caution. When people are working harder to conceive, I'm not going to be the one reason that something in your mind, even though I don't think that we could do anything to harm an embryo or the fetus in general, okay? I don't know. We are using electrical current, okay? Whether that's radio frequency, direct current, like whatever your path is, okay? I don't know because we don't study on pregnant people. And so therefore, I'm not going to be the one to do that when I know how hard it is to conceive a child when you've been told you can't.
And, going on to modality choice, a lot of our documentation over the years will specify that you should not do direct current. that usually thermolysis is going to be a safe modality to choose. And I mean, the reason for that is because you just don't want current flowing through the body,
Yeah.
essentially. And so direct current, galvanic, and blend has current flowing through the body. Now, this is all theoretical, right? We know that the current flows from pole to pole. If I'm working on somebody's underarm and they're holding the ground in their hand, then my the current only really flows through the arm.
Yeah.
So, again, overabundance of caution, like you said.
Yeah. I mean, the thing is like, why take the risk?
Yeah. That's, I guess, and ethically, honestly, this is an elective treatment. So the risk sometimes just simply outweighs the benefits for some cases.
Oh, yeah.
That being
Well,
said, I've worked on clients all the way until they popped, and others, especially those that were trying to conceive, would just completely pause treatment up until they were done with. And both approaches, I think, so long as you're okay with it, are perfectly reasonable.
my doc, when I had my second kid, um, I mean, I couldn't see below my belly. Who can see the below their belly when they're pregnant like that really well without like some mirrors, right? I didn't realize I had some extra hairs coming in on the abdominal trail. And I brought my mom to my doctor's appointment. She goes, "Can I zap that later?" And my doctor's like, "Sure." And I am like a PCOS patient going like, "Are we allowed to do this?" Like, but like
Is this allowed?
the doc was like, "Yeah, why wouldn't it be? Like, I know what you do for a living. You're fine. You're good. Your baby's healthy. If you end up going into labor now, you'll be good." And I was like, "Okay." Funny fact, he came early. So was it the hair removal? No, no.
Right? Right.
I love in the chat here. Yeah, it's better to be safe than sorry. So great comment there, Sandy, because it really is. I mean, I don't want to take the risk. Now, in second trimester, I think that this is where we can say, can we? But like, can we? But it's more like,
Mhm.
should we?
Mhm.
Right? In that spot.
I mean, the
Like,
second trimester is characterized increased vascularity, heightened pain response, fatigue, some positioning issues. The bigger the stomach gets, the more difficult it may be to lay on their backs, for example, depending on where you're working.
oh
So
yeah.
all of that stuff matters, So it becomes a something to really take into consideration.
Oh, absolutely. If treatment's considered, it should be like conservative in that spot. Understand that you're probably going to have a little bit more pillows with like you were saying before. Um, I would say skip breast to abdomen area in this time frame. Um, Ideally, keep the sessions short, but also fully documented in this space.
There's a comment in the chat from Eileen. So things happen that we can't control. And I tell my students that if, God forbid, something happens, you don't want them to have any thought in the back of their minds that it was because of the electrolysis. Exactly.
Yeah.
We know for the most part, it's not, like the things happen, but you definitely, don't want to be blamed for this.
Well,
In this
I don't know
case, if
about
she's
you.
specifying that she's talking about first trimester.
Yeah. And see, I don't know about you guys, but I know for myself, if your hairs came in at the onset of being pregnant, I don't really feel like chasing your follicles unless you want me to during that risky time. Okay.
Mhm.
Because the minute your body balances out after pregnancy, a lot of that fluff typically goes away.
Yeah.
And why am I torturing you in a time where you should probably be saving your dollars for something that is temporary? I can't even be like, oh, electrolysis is permanent. Because at that moment, it's like, no, your body's hormones reset itself and we didn't really do much to it.
And that
Um,
goes back to our past conversation about follicles becoming stimulated due to hormones. Once
mhm,
that hormone influence is gone, then as long as it wasn't, cemented by tweezing or waxing or threading,
mhm.
then they usually just go away on their own.
Yeah, absolutely. Now into the third trimester, what do we talk about
Um,
here?
and that one is also not automatically contraindicated. To me, it's just a continuation of the second trimester. But you're talking about, the stomach just keeps getting bigger and bigger. And so they're going to start to become limited more on positioning and them being able to come in and kind of, get into the like maybe laying on their backs for long periods of time, if at all. The third trimester also, as long as the client's medically stable, low risk, and they're comfortable proceeding, I don't really have an issue with it.
Myself as well. I would say those key considerations that you made. I also think that our skin's more sensitive, overall comfort. I remember in that last couple months, and mind you, when I had my kids, I don't have a lot of me this direction. So my kids grew outbound, but they just sat on my bladder. And if I had to lay flat at any point, I was just uncomfortable, right? They just sat there. And I cannot imagine being uncomfortable during an electrolysis treatment with my child in utero doing
Tap
all the
dancing on your
movement.
bladder.
I'm not going to be a very compliant patient. I'm going to be moving around a lot. So I do think about those things there. I think that as long as we can require and maintain safety and comfortability, I think that that's great. I would say Sandy has a great question. Doctor's note? Absolutely. I would say doctor's note no matter what with a pregnant person. I mean, that's what it comes down to for me. I don't know about you, but more because I worked a lot in the PCOS world that I just don't want to take the risk. But
if somebody's asking you, is it safe for me to do this? I would say get a doctor's note. Have them get a doctor's note.
Yep. Every time. And it's your CYE.
Yeah, it's not just pregnancy. Anytime somebody's like, can I do this? Go ask your doctor. Come back with a note.
I mean, I don't know. I don't know your body. I mean, if you're worried, especially if you're the worried patient that's always like, I don't know if I should do this. I need you to go talk to another adult and go find your other adult. So when we were talking about breast and abdomen earlier, I think the big restriction in there is more about hormones, right? I mean,
I mean, usually that's kind of the one consensus that we've seen. Well, two, no direct current, and then stay away from breast and abdomen. I think that for the most part, this is kind of what's been repeated across the field from different sources, that those really shouldn't be treated during pregnancy due to, the extent of the hormonal and tissue changes that occurs in those areas specifically.
Yeah. Okay. Yeah. Because I think about our pigmentation, the sensitivity, vascular changes. I also think I don't know. I had on my first pregnancy, one of my girls waxed my tummy because I still wasn't done with my hair removal on my tummy. And I just remember having her wax it while I was pregnant because I didn't want anybody to see that I had a hairy tummy. And then realizing that I wasn't showing off my tummy in a bikini anyway. So that was kind of a silly thing. And then I had to put myself through a 30-minute tummy wax that was very uncomfortable. And I don't want to do that for waxing. So I think that it's weigh it out. Is it something that you want to do?
Unnecessary discomfort, for sure.
Yeah. Ooh, gross. So we also had a great question from Melissa about, I think it was the source.
Yeah, we received a question that I think a lot of electrologists will recognize. A client came in with a mark that appeared a few weeks after a treatment. She doesn't believe that it was caused by electrolysis, but she mentioned that about 2 weeks before the appointment, her face became irritated and inflamed. She also wondered out loud whether it could have been related to a lupus flare.
Yeah. Well, I mean, she said that she picked up the sore because she thought there was a hair in there. I actually have whenever I see her next time, I'm gonna be like, here's this episode for you when it comes out. Cause it's there's an electrologist that I get to work on that has a spot she calls the colony. Okay. And it's just a spot where she has very stubborn terminal hair stuck behind scar tissue. And she's like, I released it for you. And I'm like, okay. I appreciate that, but now I got it. That's compromised skin in those moments. And I get it. She's just it's, sometimes we take those added risks as a patient, cause it's driving us crazy.
I had one of those that I just started a new Brazilian case, and she was telling me describing in detail how she tackles her ingrowns. Oh. And I'm like, don't just let me do it.
Yeah. Please don't do that.
Leave it alone. We don't need all this.
I mean, I would even say, I laugh because I watch back these videos every once in a while and I see how much I touch my face. I see how much I'm like fidgety, that kind of stuff. Um, I pay attention because I feel like I'm like a hypochondriac about how much I do it. Okay. But I see patients do it like immediately after service where they're just like, let me go feel it. Right.
Mhm.
And then all of a sudden we have them like rubbing their hands all over it. And we don't need to be like adding stuff to the area. So the fact that she like was like, oh, to free the hair, but then there's no hair visible. Now there's a bump under her skin and it takes forever and a day to heal scar tissue internally to
Yeah.
externally. And like, I understand why at that point it's like, like you're like asking yourself, like, what could this be? How do I calm it down? I mean, how are you calm?
And I mean, and that's where we need to pause, right? Because the question is less about identifying what the lesion is and more about understanding our role when it comes to something unusual that shows up on the skin.
Exactly. And it's not a diagnosis scenario. Like that's not in our scope to diagnose it. So even if a client says something like lupus, inflammation, flare-ups, it's our job to notate what they've said, not speculate it because it's not within our scope in that spot. Confirm causes, like if it's not in your scope to diagnosis, you can't confirm that reason. You aren't with that person 24/7, right? So our responsibility then becomes assessment, documentation, determining whether or not treatment is appropriate to continue.
And when you hear delayed onset, skin picking, no visible hair, palpable lump, or those are all immediate red flags.
Mm.
So, that combination really tells you that there may not be treatment, that these things might not be treatment related at all. So, probably not from the electrolysis. And even if it were, it's not something that you can work through.
No, because you're not really supposed to work in compromised tissue. I mean, once again, go back to the scope, like look at your state's or country's scope and see how much you're allowed to do. I will still do advanced electrolysis on myself whenever I have a cherry pop up. I actually did one today. I was like, oh, boop, boop, boop. But I'm not going to go and teach others until I have my new certifications in play because when I moved, my state didn't let me. And that's fine. But you have to then modify what you do until you're eligible to. So like, why go and work through something that you don't know what it is, right? Um, because you said delayed onset. I mean, there's like, it's like delayed onset. We have the no visible hair. There's a lump there. So this could be a representation of inflammation. It could be a cystic lesion. It could be an infection. It could be dermatological condition that is completely unrelated to you, but they see you the most and you are more accessible than their doctor to ask, do you know what this is? Like, I don't know about you, but the elders in my family, my grandfather specifically, would be like, hey, Steph, what's this bump? And I'm like, Papa, that's not my scope. Like, that's not my scope. I'm not doing that, right? And so I think that it's important to point here is to say that if you don't know what it is, you don't necessarily need to know what it is, but you do need to know whether or not you can treat it. So have her go to the doctor, confirm that it's something that you can work in, make sure the skin is not compromised, and ask her, hey, once we get the answer from your doc of what this is, I need you to stop messing with it so I can actually zap it like you want me to.
Yeah.
Right? Because otherwise I can't do anything to it.
So, how do we handle this professionally? I mean, first, we need to stop treatment in the area. So, when we see something quite, that large and um, what's the word I'm looking for? Suspicious.
Suspicious.
Yeah, it's suspicious looking. So, we stop treatment in that area. Second, you need to document exactly what the client reports. So, take photos. And I think that Melissa did a great job here, kind of noting down that she was telling herself it might be related to a lupus flare up and that she had picked at it and couldn't find the hair. And so all these different things, that's all part of documentation. It's very important. So get the timing, the symptoms, the picking behavior, any medical history mentioned using neutral, factual language.
Factual and neutral is very important there. I think that it's important to remember that we can educate without alarming people. You can explain that any persistent lump or sore or lesion should have a medical evaluation before you go on to their next electrolysis session. And I wouldn't book that electrolysis session until they've had the medical clearance of that area. Go somewhere else. Say, hey, we can keep seeing you. I just need that doctor's note before I can continue there. I don't think that we need to I would avoid minimizing it, right? No blame needed. It's not like you did this, I did this, none of that, right? And I really think that we need to avoid fixing it if we don't know that it's within our scope.
Yeah. Sometimes there's an image that I like when I'm teaching, especially when you're doing skin diseases. It's an image of a herpes outbreak on the cheek that just looks like little pimples.
Yep.
Right. And so I like that image because it kind of shows you just how, like, you don't know what you're messing with sometimes. And so you might be thinking it's an ingrown and you're digging and you're doing all this stuff. And then it becomes like this big old, it's a virus or it's an inflammatory, bacterial infection. And there's just so many things that could happen that you don't know about that you really need to be careful. I think that sometimes take too many risks for sure.
Oh, yeah. I mean, calm it down. Like, don't go rifling around in there. Product recommendations that when you don't know what it is, you can't recommend a product, right? So it's like you have got to put that in the right space. I think the safest guidance is simple. If we keep the area clean, avoid manipulating it, seek the medical evaluation from a medical provider or dermatologist. Those are like my two favorites. I don't know about you, but those are like the ones I usually refer out to the most. Especially when autoimmune conditions are even remotely, when you said lupus, I was like in that space. Because I also, knowing that the patient has lupus, I would also want a doctor's note saying that I can proceed with treatment because I could I could make that treatment worse, or not treatment, flare-ups worse.
Flare-ups, yeah.
Yeah, thank you. In that space. And so I think that that's all important. Once the area has resolved or medical clearance has been obtained, I think that treatment decisions can be reassessed and go back in there with no problem as long as I'm allowed to.
And that's really how we stay in our scope. So when we talk about stay in your scope, it means that, we protect our clients, we protect ourselves by responding with clinical judgment, not, guessing or trying to diagnose things that we really have no training in.
I'm like, we don't guess. Mm-mm. So what do we do?
Stop treating the site. I would stay away from it.
No insertions, okay? No scraping, no reopening the skin in that spot.
Barrier repair only. So that means, and caution, obviously, but, you can use an antibiotic ointment. Just be careful with chronic antibiotic ointment. So they can't be using it as face cream, but it can definitely be helpful in certain situations.
You just made me really think of like somebody walking into their AAA and they're like, yes, like I'm gonna put so much of this on my face.
Just goopy.
Oh, gross. I definitely think that addressing the picking behavior as compassionately as you can, but firmly is very necessary. I can't stop myself from messing with that stuff. I know how hard it is, but at the same time, give some grace, give a little humor to it. Like, I get it. That's why I do this for a living, right? You should become an electrologist. And that's how you address that.
So for the second portion of today, we wanted to shift gears quite a bit and actually talk about closing out 2025, entering 2026, our visions and goals. And I don't know if you all sat with that and maybe have thought about some of your 2026 goals, maybe personal, professional, whatever you want. If you have some that you'd like to share, go ahead and drop them in the chat. I'd love to see what are your goals for 2026. Because, as we close out 2025 and step into 2026, and as this becomes our final mentorship hour episode for the year, we wanted to just take a moment to reflect on where we're headed and why this work continues to matter so much to us.
Absolutely. Coming soon to 2026, the AES Spring Summoner, plus more virtual CEUs to keep you inspired, educated, and connected. Brought to you by Joanie Gonella and Stephanie Shields of the Electrology Education Coalition. Stay tuned and get all the updates at electrologycoalition.com. I feel like this past year, it really helped reinforce something that we've both been working towards for a very long time from our little living rooms during COVID, being like, okay, is it now, right? We both have talked about strengthening legitimacy of electrology as medically adjacent, evidence-based.
Yeah, we've wrote a paper about it.
What? Check. I think that evidence-based profession, I think that in 2026, it would continue to be our major focus. I think that especially in areas like PCOS, endocrine disorders, we have those papers that we're actually in revision right now on those ones for submission. I think that our gender affirming care paper that we submitted and just did our revisions and did the submissions, that kind of stuff, it's showing the world where electrology is playing a critical role in care, but is often a very misunderstood role.
That's right. And with that comes the responsibility to normalize higher professional standards across the field. So that usually means modeling what good practice actually looks like. So it's not just, talking the talk, but it's walking the walk.
No.
We're talking about clear documentation, SOAP notes, informed consent, ethical decision-making, infection control, a thoughtful treatment planning so that newer electrologists have this roadmap and there's just less guessing. I wanted to address one of the inputs from the chat. So Sandy said that one of her goals is to have a full client book. And so that's great. I mean, I'd like to also, when we talk about these goals, what will you be doing, Sandy, to get this full client book? What are you changing from 2025 to 2026 in order to attain that goal? Right. So it's nice to have the goals in place. Have you ever done the SMART goal worksheet?
Well, I have. I just this last month built a new lecture over that about setting up SMART assessments because I brought it up in our branding conversation and I was like, I get it. And like, as you and I start like storyboarding this new textbook that we keep talking about kind of thing, we're not saying it's happening right now. We're just saying storyboard. Okay. But as we talk about that, those are the kind of things that pop into my head is like, many electrologists, I know that in school, we try our absolute best to give you guys as much as we can in 600 hours of school. Okay. That you're talking to two educators that are like, that's not enough time. Because there's things that we know that we can continue to give guidance on. And SMART goals for me, this specific, measurable, I have to think of what the E stands for. My brain's not giving that to me right now. Joanie?
I went ahead and uploaded the worksheet that I made for my students. It has the first page has what are SMART goals and what those look like. And then there's like the two other sheets are for short-term goals and long-term goals. And so it kind of helps you like, you would think goal setting, I mean, how hard can it be, right? Like full client book, there you go. There's my goal, which is great. But let's dive a little bit deeper into it. I want it to be an attainable goal and something that you can actually realize. And so sometimes you say full client book, okay, but how? And this is where people get stuck, right? And so go ahead and take that sheet and have fun with it. Just see if you can kind of draft some of these goals that you have for yourself so that you can actually realize them.
Absolutely. I mean, like when I think about where we're at right now, from an education standpoint, I feel like one of my biggest goals for 2026 is to continue to push beyond, like just allowing my students to feel as though entry-level training is all they'll ever need and to remind them of like, yes, passing boards is very important. Don't get me wrong, but excellence comes from understanding like tissue response. It's from advanced insertion techniques. It's from complex cases. It's from a lot of data being put onto your table with your full client books in that moment, right? And saying like, this is what I could do long-term strategy when I start seeing certain trends. A lot of people go, well, how did you know to do that? And it's like, I didn't originally. I didn't know what to look for originally. It was because other people, like our mothers, right? And our mentors outside of our own families said, the people that we know had success in their lives pushed us past comfortable. And then we continued to be that way for the rest of our lives. I think that that's where confidence and consistency are built, is in how we lean in once the initial part is done.
And not everyone's at the same stage in their career. So another goal is helping practitioners identify where they are. So you could be brand new, you could be mid-career but feeling stuck, or you could be advanced and trying to just refine nuances in your skills. And in guiding them towards education that actually fits. Not every course is for everybody. And so we're not really looking for one size fits all solutions. We're trying to customize things down to, the smallest detail.
Absolutely. I feel like for this space here between mentorship hour and the eventual podcast recordings, that kind of stuff, I think that I want to see 2026 become like really case driven. You and I fell in love with those case studies when we went to US Path. I think practice focused in that space is just really cool. Real nice, real life scenarios that you guys give us. Like, I love when you guys send in the pictures with what's happened behind the scenes and kind of pop, 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 get us that whole evidence so that we can help you format like the solution to the crime of hair that's there. I think that in this spot that those real life scenarios will help us give an understanding of that there are ethical gray areas of knowledge that we have. More of like, this is what happened in my treatment room kind of conversations. I think that's really cool. I love hearing those from you guys. I feel like that'll leave our mentees with a space where they can then take that insight and apply it immediately to their practice or their business development.
So, and with Electrolysis Unplugged, one of of our shared goals is capturing institutional knowledge. So there's decades of experience in this industry that has never been written down. So these conversations about philosophy, clinical reasoning, and why we do the things that we do matter, and we want to preserve them.
Oh my gosh. We both had a little, like, when we were like typing up our notes for today, we both had like a little like drool moment. There is documents out there in the world of electrology that we would love to be able to have the initial research on those spaces from way back in the day. That would just, I think, change it. And that's like both of us have that little historical feeling of like, let's understand what they were studying here so we can see if we can mimic that again here. Making space for like nuanced conversations. Not every question has a clear yes and no because of that kind of stuff. I think that, especially when we're talking about like our patients with like hormonal imbalances, our patients who are struggling with pain management, skin response, long-term outcomes, and that's what our research project is about to do, right? Complexity doesn't mean confusion. It means that we're thinking like the clinicians that we see our industry as.
Yeah, and on the research and thought leadership side, 2026 is about continuing to translate real-world electrology practice into a language that medicine, research, and policy can actually understand. That's, electrolysis has been around long enough. We don't need to tell people that it's permanent if you're in the field. You already know that.
Yeah.
But we need to translate this into a way that other people outside of our field can understand and believe.
Yeah. Believe is a big part there.
Right. So, yeah, without that, I mean, we're losing sight of what actually happens in the treatment room. It just becomes a closed door thing. It's so mysterious and nobody really understands.
Absolutely. I feel like that ties into something that I really care deeply about. I want to encourage electrologists to think like clinicians and not technicians. I think that it's important for us to ask why a treatment responded the way it did, what variables were controlled, what we missed. When we mess up, own up, stop blaming like things that you can't really assign blame to. Like, I mean, one of the funny ones that we had a conversation with recently was we had a bunch of early in their career technicians reaching out about working with terminal hairs on a size 2 filament. And they're like, these aren't working the way they should. And I'm like, those are size 5 follicles and you went with a size 2. Okay.
Yeah.
And so understanding that, like, we have got to think about what happened and what we can do better. That way we can document it responsibly.
Correct. And we also know that business sustainability is a huge concern for a lot of you, hence Sandy's goal. So in 2026, we want to talk more openly about pricing with confidence, about scheduling realistically, about protecting your body, setting boundaries, and building practices that don't just rely on burnout to survive. So hopefully we can, make our money work for us, not the other way around.
Oh my gosh. We were both talking about that earlier. We saw that one anonymous post. Oh my God.
It was on one of the Facebook forums, and somebody was posting about how, they've been in this business a long time and they love the field, but they've started feeling tired. Like during sessions, you're glancing at the clock a lot and, just waiting for the day to end. And so they're just kind of wondering if they're getting close to burnout, which was,
it sounds like they were starting.
Could happen to anybody.
Absolutely. I think that's like, when I saw that, I thought about like career evolution. You and I, literally, just so everybody knows here, one of the hardest things about being an educator, and I'm sure that Eileen can pop on about this, and if Kayla's here too, okay, is finding qualified teachers that want to continue the profession, because there's only so many teachers out there. So like, I think that like looking at this and saying not everyone needs to be a full-time technician, right? And break their back over all this kind of stuff. I mean, and be in the treatment room forever, full-time, all the time. I think that there's a lot of compassion fatigue that can happen when people are kind of consistently irritated with a process that we know is arduous, but they haven't quite understood that in that space. So being able to say like, hey, like, let me fulfill my goals and be able to teach this better. I think
Eileen said her number one goal is to find another educator.
Oh, absolutely.
So if you guys want to move to Maryland, there's a school looking to hire.
Oh my gosh.
This is actually going to go out to, we're going to go straight through the podcast. So,
oh my gosh.
So this is all free advertising, Eileen.
You have 3 schools that are begging for educators. I'm just saying, in 2026, like if you got 5 years behind you, multiple certifications, and you love to learn, we got programs for you to come teach for us. That's what I got to say.
And in her school, it's MEEC, right? It's Maryland
MEEC.
Education, Electrology Education. Eileen, I'm sorry. If you want to unmute yourself, feel free to drop.
Maryland Electrolysis Education Center.
There you go.
Right?
Yeah, mdelectrolysiseducation.com is the website.
Yes, so there you go. I'm so like sorry. Was not picked about that when I named it.
No. I always get mad that our profession is electrology. It's such a long word. I'm like, I have too many letters in here. But I think that's like,
makes it hard.
I like get people like energized about research and validate our paths of work so that we can start normalizing that our work is actually real, that we're not faking it. Yeah. So that's me.
So on a personal level, one of my goals for 2026 was about being more intentional about where I spend my energy. Because I tend to be all over the place and I do say yes to a lot of different projects. It takes me a lot of different places and I'm very grateful for that. But at the same time, there comes to a point where you have to be able to just focus, right? So it's about saying yes to projects that will align with my values, about moving the profession forward, and about respecting the depth of this work.
Yeah. When you talk about like that workload balance, I think that we forget that we're humans. Just the other day, one of my friends posted this thing about like we work in a space where we're always rushing. Everything seems urgent or emergent. And like one of my favorite phrases, I know I'm going to say it wrong, is that like your emergency doesn't require my urgency or vice versa. It's one of the two. They feel the same to me, just so you know, in those moments. And like, I've always worked, when you talk like taking on a lot, I'm the queen of saying yes into things that I don't got time for, right?
Yeah.
I'm like, we'll figure it out. It's fine. It's fine, right? And so recently I've really worked on establishing a solid no. Okay. I'm so sorry. I don't have the ability to do that. Let me see if I can help you find someone. Or if you don't mind pausing that project, I can look at it later, right?
Yeah.
Oh, that was a really hard thing. That sentence was a really hard thing for me to learn when I was working up here, right? So I think that that's big. For myself, I have some personal education goals for next year. I've got some goals to figure out. Like, I unfortunately have like a bit of a time clock against me to figure out how I can find a bigger space for Zapmaster or create that space. And I've got 3 years to do it. And whether it's a build out or building out a facility, that like one of those already is taken. So now I got to figure out, and I got 2 years and like really I'm like, so that is like the Stephanie thing that's happening right now. That's happening behind all of the other spinning plates of my 2026 goals. And I'll figure out how to balance it out.
It's going to be a lot.
Yeah. So, and then obviously continuing this chaos with you, I am going to have a little personal shout out moment to my bestie Electrocutie over here moment. Like, this is now multiple years of us on this endeavor together. And like, I think a big goal for me was to find connection with people who saw what I saw as potential in our community. And the fact that I found out with a friend, I'm like, there's my little, like, I'm not going to get teary-eyed, none of that kind of stuff. But that is a huge goal that was realized. And I didn't even realize that we were making that happen until we were past some of our milestones. So
yeah, exactly.
That's me. You're welcome. A little bit of ham bone from Stephanie.
So as we close out this year, we hope this conversation gives you space to reflect on your own goals for 2026. I did drop the drive link of the PDF for the SMART worksheet.
Thanks.
So feel free to use it. It's my gift to you. Happy holidays. And hopefully it can help give you clarity when it comes to goal setting, honestly.
Yeah. I think moving forward thoughtfully is how we build longevity for ourselves and for the profession.
Right.
So
we shall meet back in January. Yeah. January 6th. So honestly, this was a great year. We've had so many episodes.
So many.
And thank you so much for those of you that join us, like honestly, week after week. It's really great to have you here. So grateful.
Yeah, so grateful. I can't believe some of you, Anita, get on at the crack of dawn, right? The beginning of the day. And other you are way late, like Eileen. And you guys are choosing to be here to fill your minds with our voices and your questions. And I think that's pretty cool. So thank you.
Yep.
Yeah.
All right, everybody.
Happy holidays.
Next time. See you next year.
See you next year. Bye, guys. As we close out this episode, we also want to share what we're building as we head into 2026, both personally and professionally.
For us, 2026 is about refinement. It's about stronger education, deeper research, and clearer boundaries.
We're expanding advanced coursework, continuing our research initiatives, strengthening mentorship, and advocating for standardized ethical electrology practices.
And personally, it's about sustainability, longevity in this work, protecting our bodies, our minds, and our purpose.
Our goal is to help electrologists not to survive, but to thrive with integrity.
Thank you for trusting us with these conversations.
Join us next time on Electrolysis Unplugged. Until then, stay curious, stay ethical, and know when to pause.